Good evening.
Hey, good evening, Professor Debbie. We're glad to see you here. We're actually waiting to see you here so that we could start.
Okay.
Thank you so much for consenting to give us this time. Thank you. We appreciate it.
You're welcome.
Okay, so good evening, everyone, and you're welcome to the bi-monthly clinical meeting of the Infectious Disease Pharmacists of Nigeria, a specialist arm of the Clinical Pharmacists Association of Nigeria, CPAN. And today we have a very engaging topic and one that is very close to my heart. We're going to be talking about establishing and sustaining antimicrobial stewardship programs in pharmacies, prospects and challenges. And we also have a very, very engaging speaker. I consider us highly privileged to have gotten her to accept to speak with us. We have with us today Dr. Debbie Goff, who is a professor of pharmacy practice at the Ohio State University College of Pharmacy. She's an infectious disease specialist, a very well-known one. And she's in charge of the global antibiotic stewardship of the Ohio State University Medical Center. She's also a global antimicrobial stewardship expert. She's known all over the world as an infectious disease specialist pharmacist. And she was a founding member of the antimicrobial stewardship program at the Ohio State University Wexner Medical Center and the College of Pharmacy in Columbus, Ohio. Our speaker tonight is a TEDx speaker on antibiotics, just in case there's an infection. She founded the OSU South Africa Train the Trainer Antimicrobial Stewardship Pharmacist Mentoring Program in 2012. And she received the OSU Distinguished International Outreach and Engagement Award for her work in South Africa in 2019. She's one of the 25 global experts selected by the WHO, the World Health Organization, to implement stewardship in low and middle income countries in the world in 2020. She lectures nationally, she lectures internationally. She has more than 150 publications and several research grants, which we cannot name here. She has several ongoing researches that are global in South Africa, in Lebanon, in Latin America. From what we've said so far, you can agree with me that our speaker tonight breathes, speaks, and lives antimicrobial stewardship. So if I were you, I'll get my writing materials, I'll get my recording devices, and I would not allow anyone to distract me. And so at this point, we welcome you warmly, Professor Debbie Goff. You have the floor. You're welcome.
Thank you so much. All right, let me share my screen.
Yes, you can.
There we go. All right, great. Well, good evening. It's really quite an honor to be your guest speaker tonight. And I am very excited to meet with all of you and just share some of my experiences. So we're going to talk about establishing and sustaining antimicrobial stewardship programs. So my work globally is quite extensive. These are all the countries that I've been to help implement antibiotic stewardship. So I have seen it all. I've heard every reason why you can't do it. There probably isn't anything I haven't seen at this point. And I am here to assure you, you absolutely can do this. And I'm going to give you some guidance on how to succeed. So let's just start with defining antibiotic stewardship. Stewardship means overseeing something worth protecting, and that something is an antibiotic. And when you really believe that, you will become very passionate about this, because it is not just an issue for infectious disease experts, but it is a surgical issue, and that's how you relate this to surgeons. It's a cancer issue. It's how you talk to oncologists. And importantly, it's a patient care issue. Everyone will be affected by an antibiotic-resistant infection at some point in their life. It may not be you personally, but it will be your parents, your grandparents, your children, or a colleague or a friend you work with. So the issue is a problem around the world. It is a much bigger problem in low middle income countries, and Nigeria has a very significant issue with antibiotic resistance. So the world needs to function as one. We have lost effective antibiotics around the world, but it's even more of an issue in countries like Nigeria, because you don't have access to all the antibiotics we have in the United States. And there's a lot of challenges in terms of resistance rates in multiple countries. So let's define who is an antibiotic stewardship. Who is an antibiotic steward? It is not just the people on the team of antibiotic stewardship, which should include an infectious disease trained physician, an infectious disease trained pharmacist, a microbiologist, an infection control nurse, a data manager. That's not the reality in most low middle income countries. But the most important thing to recognize is the antibiotic steward is really anyone who prescribes an antibiotic to a human or animal, cares for a patient that's taking an antibiotic, or the community pharmacist selling antibiotics, or that patient that demands antibiotics. All of these should be the antibiotic steward, because as a clinical pharmacist, I can't control all of these areas and I can't influence all of them. So each person really needs to be invested in this. And I think the COVID pandemic taught us there's not one healthcare provider that could manage COVID alone. And so some really beautiful things came out of the pandemic. We have to function as one. We need each other. And antimicrobial resistance is now called the silent pandemic. We need each other, and that's what stewardship is all about. So when you are going to become the antibiotic steward, you must understand the why in order to change a physician's behavior prescribing of antibiotics, and also your patients who may take antibiotics before they even come to your hospital. And so they have prior exposure and they present with antibiotic resistant infection. So ask yourself, what is your why? In the United States, antibiotic stewardship is required in all of our hospitals, but because it's required is not a good reason why you're doing it. You really have to understand the why. If you're working with a surgeon and they feel that you're just telling them what they can and cannot prescribe, you will never engage them in antibiotic stewardship. So there are really 4 ways you have to learn how to influence people. Doing antibiotic stewardship, you must have infectious disease knowledge, but almost equally important is you have to be able to influence people, because you are asking people to change the way they currently prescribe antibiotics. So to be a great antibiotic steward, you really have to be interested in other people. Learn to smile. No one likes to work with unpleasant, grumpy people. Be a good listener. So you rarely will have success telling doctors you can't use that antibiotic. Listen to why they're prescribing the antibiotic. What is their reason? And then you have a discussion with them. So you have to learn to talk in terms of the other person's interest. As the pharmacist, you might be interested in making sure the right antibiotic is prescribed for the right infection. Of course. But the other person may not really see it that way. They will prescribe the broadest spectrum antibiotic so it covers everything and they don't have to think anymore. That's not good stewardship. But until you understand that's their reasoning, you're not going to be able to change their prescribing habits. So I really want to start with my dear friend, Dr. Ben Nwome. Ben trained in Nigeria. His family, his mother still lives in Nigeria, so he comes back frequently. He is the professor of surgery at The Ohio State University and a pediatric surgeon at Nationwide Children's Hospital that I'm going to use as my example of how did we end up working with each other, because it's a very interesting story. And Dr. Nwome actually did a lecture for a Nigerian microbiologist. I was scheduled to do the lecture, and unfortunately my mother passed away, and I called him and said, I am not going to be able to give that lecture tomorrow. And he stayed up all night while he was on call for surgery at Ohio State, and he put this talk together. And he shared the slides with me, and this was one of his slides. How did a busy surgeon like myself become an unlikely antimicrobial stewardship advocate? Because when I met him in 2015, and he asked me, what do you do? And I said, I'm an infectious disease pharmacist on the antibiotic stewardship team. And he said, oh, what is that? And I said, oh my gosh, that hurts. You don't know what this is. He goes, no. And I said, oh, you're going to need to stick with me, and I'm going to teach you what antibiotic stewardship is. And that's how our friendship started. And the reason I was connected to Dr. Nwome is because I've worked my whole career with Dr. Ellison on the far left. And I went to him in 2015 and said, how can I teach surgeons about emerging antibiotic resistant infections and what antibiotic at our hospital is the right one to use in real time? And he said, oh, you need to be on Twitter. I said, what? And he said, let me connect you with the most prestigious surgeon in the world on Twitter, and that's Dr. Nwome. I never knew him because I practice adult stewardship, not pediatric. And that is how I met him. So it's an interesting example. He had knowledge that I didn't have, how to use Twitter, and I had knowledge that he didn't have, how to be an antibiotic steward. And so we were both very genuinely interested in each other's area of expertise. And so when he taught me how surgeons were using Twitter to engage with each other globally, to learn from each other, to advocate each other's academic work, I was really interested. And I said, well, I will get on Twitter and start tweeting, but I want to do this as a study. I don't really understand how this works, but if I'm going to enter into this, I want to study it and see, can I actually engage surgeons in antimicrobial stewardship via this new thing called Twitter. So this was back in 2015. And that is how our relationship started. He taught me Twitter, and I taught him about responsible antibiotic prescribing as a surgeon. And we were genuinely interested in each other's knowledge. And that is such a key factor of stewardship. We developed a relationship and respected each other and then moved forward. So never forget the human element of antibiotic stewardship. And then I had the great fortune of getting this random email. Would you be willing to mentor this pharmacist coming to Ohio State for 8 weeks? And I was ready to say no. But then I thought, oh, maybe I could figure it out. And here was this gentleman who I know you all know, Ubaka. And what a blessing it was that I chose to say yes, because we have become lifelong friends. But importantly, I listened to him. I learned first how he was selected. And I clearly knew I was working with someone that was a high achiever, because only those were selected for the Mandela Washington Fellowship Program. But I met with Ubaka and listened, what would you like to learn from me during your 6 weeks here? And we listened to each other. And I really did not know about the practice of pharmacy in Nigeria. And I was very interested to learn how are pharmacists trained in Nigeria? And then how do you do antibiotic stewardship in your country? Of which he said, well, I'm not really sure we are, but this was back in 2016. And so I said, oh, well, you're going to help implement that because every country should be doing it. And so we really started on this beautiful journey. And he was here during a national holiday, 4th of July. We celebrate our founding fathers in the United States. And that's Ubaka at my home, because part of the importance of working in other countries is also understanding their culture and how the citizens live. And so Ubaka was at my home for this holiday for a cookout and meeting my family. But importantly, when I first met with him and listened to his goals, I could clearly tell him, if you will work towards excellence in your 6 weeks here and not be average, you will go far. And I will help you, but only if you want to work towards excellence. If you want to be average, I'm not the right person for you. And Ubaka worked harder than anyone I've ever worked with. And so there he is on the right, because my belief is when you publish your work, you teach the world. And I said, Ubaka, I'm going to teach you how to write a paper. And it was an amazing experience. And he worked harder than anyone I know. And so I respect that. And that's why I'm willing to give my time to talk with all of you today, because I know there are more Ubakas in Nigeria. And what was really amazing is I was working with Dr. Nawome on Twitter, and I knew he was from Nigeria. So I asked him, I have this Nigerian pharmacist. I would like to meet together and see how we could enter into doing antibiotic stewardship in Nigeria. And so he did meet with Ubaka. And wouldn't you know it, you're a very large country. They start talking and come to the realization they are from the same city. I mean, what were the odds of that? And so when Dr. Nawome returned to Nigeria, they sent me this cute little picture. He made time to visit with Ubaka and have dinner. And they were sending me this little tweet. It was just an amazing friendship. But importantly, Dr. Nawome is a very prestigious Nigerian surgeon in the United States. In fact, he's the past president of the Nigerian Physician Association in the United States. And that is when I realized we may utilize his reputation to help him and the country of Nigeria break down some of the barriers in hospitals for pharmacists to interact with physicians. I was actually informed that some pharmacists are not even allowed to talk to physicians. And Dr. Nawome knows this very well, because when the Nigerian surgeons come to train at Ohio State and refuse to listen to the nurses, he has to sit them down and tell them, you will respect the nurses, you will respect the pharmacist, and you will listen to what they tell you to do, or you will be returning to Nigeria. We do not work in a hierarchy. We work as one team, and you are a member of this team. So it's very different, I've been told, than the practice in Nigeria. So that hierarchy within medicine is important to understand. So the first part of being a successful antibiotic steward is the doctors you're working with must know and trust you. So how do you build that trust? Stewardship is hard because the recommendations we're making are being made to physicians that are not asking for our advice. And so it's very easy for them to dismiss you as a pharmacist when there is no professional relationship. So it takes an effort to build that relationship. And keep that in mind. That really is step one. And Dr. Nwome made it very clear because that's how our relationship started. I didn't tell him, oh, you're using the wrong antibiotics in your surgery. It was, I wanted to learn Twitter and I respected his knowledge and he wanted to learn what it is I was doing. And it was just such a beautiful start to our friendship. You have to have the interventions tailored to the professional identity of the person you're working with. So myself in working with surgeons, I have a very different approach than when I work with internal medicine doctors. And Dr. Nwome taught me some of the perspectives of a surgeon. So this is Oyetola Babarende. When she came to Ohio State to train, she's a Nigerian pharmacist that was studying in South Africa. So she was part of my South Africa mentoring program. Dr. Nwome, as a busy surgeon, is part of the mentoring program. He meets with every pharmacist I train. They have a one-on-one, 1 hour meeting to ask a surgeon anything they want. And usually their question is, as a pharmacist, I'm afraid to approach my surgeons. Some of them are not very friendly, and I don't know how to approach them. And you can see them smiling here. He really helps them learn what it is to talk about. And as he says, patient care is complicated. You cannot do it alone. I'm a surgeon. I want to work with my hands in the operating room. I don't want to be an expert at antibiotic therapy. That's why I picked the broadest spectrum one. I figured something will cover this. That's how he's picking an antibiotic. That is what you need to listen to. And that is how you can start to develop a rapport with that surgeon. There they are on patient care rounds. A multidisciplinary team, the neonatologist, the nurse, the dietitian, the pharmacist, and the South African pharmacist. So how can a pharmacist in Nigeria contribute to antibiotic stewardship if you're not trained in infectious diseases, you don't round with the doctors? What do? Well, Dr. Nwome taught me, and I have not been in your hospital, so I am speaking from his knowledge he shared with me and some of the things Ubaka taught me. Dr. Nwome told me as a surgeon, when he goes back to Nigeria, one of the most common problems as a surgeon is he cannot get the antibiotic prophylactic agent he wants. And he has to send his patients to go to a community pharmacy to buy the antibiotic. So if that's an issue in your hospital, you have an amazingly important role. You, as the pharmacist, can help physicians select quality pharmacies. If your pharmacy doesn't have these agents in stock and they have to buy them somewhere else, Dr. Nwome said he would like the pharmacist to guide him as to which pharmacy they should go purchase them from. Can you help maintain an adequate supply of antibiotics? So the supply chain issue of drug therapy is a very important component of stewardship, because if you can't get the right antibiotic for the right infection, patients don't do well. So even if you are in the primary position of dispensing medicine, you can build this rapport with your doctors to make sure you have adequate antibiotics on hand. And unlike this photo that we observed in South Africa, where a lot of antibiotics and drugs are bought with bribes to pharmaceutical companies, and they buy way too much and then the drugs expire. So all of this is expired drug therapy, which obviously is a waste of money. The pharmacist has a very important role here. So Dr. Nawome shared this article, and I would encourage you to look at, I don't know if it's a physician or a microbiologist highlighted there, but that is a clinician in Nigeria that was a part of this study. And this study really resonates with Dr. Nawome because he is a gastrointestinal surgeon. And this paper was a collaborative paper with many countries, including Nigeria. And here's what they found, that surgical infections were higher in low middle income countries. And a lot of times it was the inappropriate antibiotic was selected almost 50% of the time. So you can look as a pharmacist, there are many things that you could help in terms with the physician, making sure it's the right dose and the right duration, and that the antibiotic is delivered to the patient's bedside in a timely fashion. So if you're in charge of delivering ward stock, just don't put the antibiotic in the ward stock room, because the nurse never knows that it's been delivered. And several hours could go by before the busy nurse ever makes it to that ward stock room. Tell the nurse the antibiotics have arrived and bring them to the bedside. That's a very important contribution to stewardship. And these are all the beginning fundamental practices in stewardship any country can do. So antibiotics continue to be overprescribed, or what I call just in case prescribing. Surgeons are very quick to say, when I ask them, what is it that you're treating? Oh, I actually didn't get any cultures, but just in case they had an infection, I wanted to give them antibiotics. And that's not appropriate. But in a hospital, it's called hierarchy. The physician makes all the decision, and every healthcare provider is under them. So if you're a pharmacist, you may not have the opportunity to talk to the physician because of hierarchy. If you're the physician in training, the senior physician is the one that makes all of the decisions. There are often gender imbalances and discrimination. I am a female, and I have experienced that early on in my career. There's age discrimination. If you're a young female pharmacist trying to talk to a senior male physician, there are barriers. And then there are cultural barriers in countries and public pressure. These are all the things you must learn about when you do antibiotic stewardship, because all of these things are the reason sometimes the recommendations are not followed. It's not because you're not making an appropriate recommendation. There could be some of this hospital hierarchy that is very difficult to overcome. So the World Health Organization, once again, has made a call to action for all countries to get on board with antimicrobial stewardship. They're calling it the silent tsunami. All countries are recommitting, including Nigeria. There are many World Health Organization toolkits to guide you. I am an author on both of them, on the left and the right. I worked very hard to make sure the pharmacist had a very important role in these toolkits based on my work in all these low middle income countries. We do more than just dispense medication. So I suggest these are, just Google the WHO and you can download these toolkits for free. There is a plethora of information in these toolkits. There's no reason pharmacists can't do stewardship. All of the guidance you can imagine are in these toolkits, but people just don't use them or read them. And here's part of the problem. When you want to change anything in a hospital, you must have all 5 of these colored boxes or problems occur. So the one I'm highlighting, because we're doing this webinar right now, clearly you all have a vision of pharmacists being involved in stewardship. And you have incentives because your country has a lot of antimicrobial resistance. I'm sure someone in your family has paid the price for antimicrobial resistance, and that might be the death of someone in your family. Resources are very limited. There's an action plan. You have a national action plan. But what if you don't have the skill? You're actually not trained in infectious diseases, and now you're being asked to do stewardship. All that does is create anxiety because you'll be afraid to do this. And so you have to have all 5 components to get to change occurring in your hospital. So I've recognized that, and that's where back in 2010, I started my Train the Trainer program for South Africa pharmacists. So we've published our work, and you have thought leaders in your country. Ubaka is one of them. You have experts to help train you on this journey of antibiotic stewardship. You have a Nigerian surgeon, Dr. Ben Nwome, willing to mentor and train. He's an amazing man that is Nigerian and understands the barriers you're facing. So I want to really conclude, because I want to be able to answer any of your questions. Antibiotic policies and publications are not enough to make this change occur. It is the individuals that drive change. Be a change maker. Don't keep trying to figure out. You will never have everything in place in order for you to start. If you wait for that, it'll be 20 more years. There's never enough money to do anything, including in our country. You will have many, many barriers. If you wait for every barrier to be gone, you'll be waiting forever. Just do it and get started now. So be the next change maker in Nigeria. Thank you. And I'll be happy to take some questions.
Thank you, Professor Debbie Goff, for that very inspiring and challenging presentation. Perhaps, I do not know, I was informed you would like Professor Ubaka to make some comments. Would you want that to come up before your questions, or would you want to take your questions before his comments?
No, I would love to have Ubaka make his comments, and then we can really both take questions.
Okay, so Professor Ubaka, can you make your brief comments?
Hello, good evening. Are you hearing me?
Yes,
I am good. 1 second, my dog is barking. Okay, I'm sorry, I'm back.
Debbie, good evening. Okay, I think it's afternoon over there at Colombo. Thank you very much, Dr. Onodugu. I didn't know I was going to make a speech, so I didn't prepare for any. But first to say, Debbie, you look very good in those beats. I remember those beats. I gave them to you.
Yes, this is from Nigeria.
Yes. I want to tell every pharmacist on this Zoom that Debbie most definitely is the right person who can help pharmacists in Nigeria, help the system in any way she can to get antibiotic stewardship rolling. I'm just involved now in a multi-country study from it's happening in South Africa, and it involves RTGs, Professor Nabi Shilak, and we hope at this point, and it's a pharmacist physician co-led multi-center study. I think this is why it is important. Is this study is trying to bring those 2 key players in the hospital setting to agree to begin to practice stewardship. I think why it differs from some of the activities we've done, especially even with your PhD, Dr. Onodugu, is that we focus on one health professionals leading the race, and it could be easier for them in the United States and in development. But I think such approaches begin to contextualize how Africa works and how difficult the system is, especially from the point of view being hierarchical. So no matter how slow we move, the most important thing is to gain speed and to gain momentum. Hopefully, with this organization that has been opened now as part and parcel of CPAN, to drive the narrative and the progress of antibiotic stewardship. I am hopeful that whenever expertise is needed, we would always provide. And also as hospital pharmacists, community pharmacists, whenever we have the opportunity to be engaged in one form of research or in some form of collaboration to help drive antibiotic stewardship in our system, we should be all willing at every time to be part of it. So thank you. Let me not take up much of time and ask the question already. It's nice really having to see my sweetest. Bye, everyone.
Okay, thank you, Professor Obaka, for your comments, and they are well taken. And we're sure that something good will begin to happen, or we will expand frontiers as we move on. And so please, I would like to invite all those who have questions, please, so that we can be orderly. You raise your hands. We will recognize you. You ask your questions as briefly as possible. It's also okay to put your questions on the chat room so that we can make the most use of our time. When we recognize you, then you can speak. So please, so be orderly. Okay, Dr. Ibrahim Hazib, please ask your question.
Good evening. Thank you so much, Dr. Deba, for that wonderful presentation. So, my name is Ibrahim Hasib. I'm an infectious disease pharmacist and trained in Malaysia, actually. So, I returned back to the country like 2 years ago, and I haven't been working in the hospital settings now. And one of the things I realized is that when we look at the settings in Nigeria, we really have a lot of issues when it comes to technical know-how or knowledge as regards to stewardship among pharmacists. And so I just want to ask, how do you think we can include in our curriculum? I see that most of the university students graduating that they're doing kind of internship and they have a minimum knowledge when it comes to antimicrobial stewardship. Even if you ask them, actually don't know about antimicrobial stewardship. So how do you think we can start to include all these things in our curriculum, starting with from the university level? That's number one. And number two out of it is, we already have people in the system that's already working in the system and still not aware of the antimicrobial stewardship. Now, what are the processes you think we can go to? We can actually start to introduce all these things to them, so that, because if we have just a view of the pharmacies that are doing it, I think it won't be effective than having everyone to be educated when it's regards to antibiotic stewardship. And I think I just leave it at that. Two questions. Thank you.
Thank you, Dr. Ibrahim. Any other questions? I think so she could take them all at once. But if there are no more questions.
There are questions in the chat box.
Okay, so while we get the questions out of the chat box, Dofan Shambe, you can ask your question. Please go straight to the point. No introductions, please. Ask your questions.
Okay, good evening. Thank you so much. We recently tried, we had a bit of a baseline analysis of antibiotic use in my facility. It was actually done in conjunction with an NCDC, trying to set up an antimicrobial stewardship program in the hospital. And one of the things we observed was that there was
I'm so sorry. I think we lost the connection.
Okay.
So let me address.
You can put your questions on the chat room. We can't really hear you. And
So
I
while
think-
she's putting the question in the chat room, let me address Dr. Hazib's question. So how do you include stewardship in the curriculum? So I think it absolutely needs to be in the College of Pharmacy curriculum because they need to learn about this when they are students. And it should be part of the infectious disease component of your program. So again, I don't know what your College of Pharmacy curriculum looks like, but at least at a minimum, they need to have a 1-hour lecture so they have become familiar with the term antibiotic stewardship. They understand why the program is necessary in the hospital and community within Nigeria and how a pharmacist plays a role in antibiotic stewardship. So those are the components that I think have to be stressed. Learning the specifics of how to make interactions, I would probably defer that to if they do rotations in the hospital setting and let that be taught there. But it does lead to one of the other questions someone asked about doing community pharmacy stewardship. How do we even start to move forward? And that is a very big problem in many countries because the community pharmacist makes their living by selling antibiotics. So to just tell them they need to stop selling antibiotics is not a solution. And I remind doctors about that because I said, you know, if we told you we were going to cut your income by 25 to 30%, how would you perceive that? No one's going to agree to that. So they really have to become more educated as to helping patients that walk in and demand an antibiotic. They may need an antibiotic or they may not, but the pharmacist should really have questions prepared to ask the patient, will an antibiotic be the right drug for you, or do I really believe you have a viral illness? And when they understand they're really harming all of society by giving antibiotics to everybody, they become more agreeable to not just keep selling antibiotics to every patient that walks in. But again, they have to understand the why. Why shouldn't I? That's how I make my money. And so you have to really explain the bigger picture. And in other countries that has worked. So in India, where you can walk in and get any antibiotic from any pharmacy, they have agreed to a tiered system. So there are the WHO reserve antibiotics, such as colistin, and the pharmacists have agreed we won't just give that to anybody. And so it's a very thought through strategy that's actually working in India. Is it perfect? No, but it's a starting point for community pharmacists to get involved.
Okay, thank you, Dr. Debbie. There are several other questions on the chat room. Someone is asking, any plan for training? How will pharmacists in community settings benefit from the antimicrobial stewardship program? Any plan for training? Some are asking for stewardship principles that will give the best benefits from the use of antibiotics. And then what do you do when the antibiotics you have available won't work for an infection?
Thank you. So I see a lot of these questions. You have to accept when you're in a country with high levels of antibiotic resistance, there's a high probability the antibiotics will not work. And unfortunately, the patient pays the price. Some will actually die because they have an untreatable infection. And as sad as that is, it is reality. And you use that as an example of why we need to be more in tune with antibiotic stewardship. So for every patient who dies from an untreatable infection, it's a teaching moment. And your country must do better, or you're going to have more and more people die from antibiotic resistant infections. And so, one question is, what does a pharmacist do when the doctor insists on combinations when the health of the patient is at risk? So I would imagine that means prescribing, let's say, a couple antibiotics that might affect the kidneys and cause renal failure. So, doctors start giving multiple antibiotics when they don't know what they're doing. They don't know what organism the patient is infected with. And I am very aware that obtaining a culture is not the norm in your hospitals because the patient has to pay for it out of their pocket. So they don't even get a culture. So they don't actually get an organism, and you can't assure them that the antibiotic they're giving is the right or wrong antibiotic. So it's very difficult, and you can't really fault the doctor if the patient's getting worse for them adding additional antibiotics because you don't know what they're treating. And if the patient's declining health, it could be because they aren't being treated with the right antibiotics, so they start adding more of them. You're in a very difficult situation when you cannot get microbiology data, and that's very common in many low middle income countries. Nigeria is not alone there. It makes the job of the antibiotic steward more difficult. In parts of South Africa, they're using colistin as a first line agent for exactly that reason. And I can't say it's wrong because they have high levels of gram-negative resistance. So again, the way we're moving forward, there's a large grant coming out from the United States with Nigeria to train microbiologists to be able to provide effective, timely culture results. So we are working on strategies to improve some of those barriers. You cannot correct all of them. So what I encourage you to do is some of these questions you're asking are the most difficult questions of stewardship. It's not where you should start because there's no easy answer when you don't have the ability to have cultures help guide you to antibiotic decision making. So find ways that you can make a difference today without money. There are many ways, such as the timing of the antibiotic. That's what we did in South Africa. The pharmacists were very comfortable assuring the stat antibiotics were actually delivered rapidly. So there's a lot of ways you can get involved and contribute to improving patient care that don't involve getting culture data and some of the things that just aren't options in your country in all hospitals.
Okay, thank you, Dr. Debbie. I think you've answered in part the last question on the chat box I can see here from Dr. Joda, asking about low-hanging fruits of AMS. I think that's part of what you referred to. And perhaps I would like to add, for the one who is asking for training, there are a lot of formal trainings. In fact, there was a company, I think it was AstraZeneca, some years back that did comprehensive training for community pharmacists on antimicrobial stewardship. I was part of it, and the turnout was very, very poor. And I don't think they were encouraged to continue. So sometimes the resources are there, but we don't actually make use of them. Even as we speak, there's a lot of training material online. There are a lot of videos, a lot of YouTube, videos, a lot of tweets. There's so much out there. But if you really want to know more, you can. And you can start something within your area. That's what she's talking about. Let's stop the big things. Let's start from the low-hanging fruits. I don't know whether there's any other question before we give room to our national chairman of CPAN. I think I saw him here to make a few comments before we round up. But before I call him up, I would want to remind us of a few key points that Dr. Debbie mentioned this night. She said, First of all, the people you want to reach out to have to know and trust you. You need to build the relationships. And I think that's also somewhere we as pharmacists, we do not do very well. Cultivate those relationships with the surgeons, with the nurses, with the physicians, with the pediatricians, with the community pharmacists too. When they know you and trust you, they can listen to you. And she said that ASP interventions must be tailored. It's not one size fits all. You have to tailor whatever you want to do to the audience or the people you are targeting. And she mentioned something very, very key, that supply chain of antimicrobials is a very essential part of stewardship. It's something we all as pharmacists can do because that's one of our primary responsibilities. In your institution, whether your hospital or in your community pharmacy, do you have the antibiotics that are really required? Do you have access to them? Do you provide them? She talked about making the antimicrobials available by the patient's bedside. Can we think about that? She talked about timing. Can we do that? What about the administration? There's so much we can do and start with. And I repeat her last words in this presentation, that it's not policies that drive change, it's individuals that drive change. And she's challenging each one of us to be the next change maker in Nigeria. Did I summarize well?
You did a beautiful summary. I now put you in charge of stewardship because I can tell you are a change maker.
Thank you very much. And
yes.
So we give this room. Dr. Joda, are you still raising your hand? I thought we had handled your question. Okay, so please briefly.
No, I just wanted to make a quick comment.
Okay.
Just to add on to what you said about training materials being available online. Currently, there was a grant call for an antimicrobial stewardship program in the country, and it was by the Commonwealth Pharmacists Association in association with some other partners. And a team from Lagos University Hospital and the Faculty of Pharmacy in Unilag actually got one of the grants, and we were just completing that program. And part of it was part of the outcomes was to train pharmacists and other members of the healthcare team in antimicrobial stewardship. And we invited pharmacists in Lagos and Ogun State, both hospital and community pharmacists, to be part of that training. So, and what we found as part of the deliverables for this program is that there are a lot of certification programs that you can even do online through WHO, through the CDC, that you can equip yourself for the practice environment that you are in. I put that statement, low hanging fruits, in the chat box to agree with Professor Goff that we should not try to break all the silos, all the barriers, but there are some things that we can definitely do. And when we do those, we start with those, then there will be opportunities we will use those low-hanging fruits to build these relationships that she talked about, and that is so very important. And then we can then progress and move on and do more in whatever areas we find ourselves. Thank you very much.
Thank you, Dr. Joda. And I think to buttress that, if I share just a few minutes of my own experience, I started with the pediatrics. We're able to get a stewardship champion there from the physicians, the pediatricians, and I was able to educate them. I still work with them till now on stewardship matters. We're not where we would love to be, but we've left our starting point. So it's doable, inch by inch, step by step. We win one, we go to the next. And like we've said, we get the low-hanging fruits and we grab onto them and hold onto them and execute them. Okay, so I don't know whether Dr. Madu is here. Please, could you unmute yourself and then you give us some comments, after which I think I'll call on Dr. Issa, who is our admin for the infectious disease pharmacist. If you have a few comments, then we round up. Dr. Madu, please.
All right. Greetings, everyone. Please, am I audible enough? Can you hear me?
Yes, you are.
All right. Good evening, Madam Moderator, for giving me the opportunity to speak. Let me first of all thank Dr. Deborah Golf. I can see she's a fellow of the American College of Clinical Pharmacy. Of course, American College of Clinical Pharmacy is one of the first clinical pharmacy or is the first clinical pharmacy association in the world. And today we are having a fellow of that college being our guest speaker. We thank you so much, Dr. Deborah, for being in our midst. Let me say something a little bit about CIPAN and Infectious Disease Pharmacists Association of Nigeria. CIPAN is barely 2 years old. As I said, American College of Clinical Pharmacy, being an association of clinical pharmacists in the US, is so many years old. CIPAN is just about 2 years or 2.5 years old, whereas Infectious Disease Pharmacists, being a specialty group of CIPAN, is just about, let me say, 5 months old. And today we have an experienced person from where clinical pharmacy originated, a fellow of that college, and she is with us here, opening our eyes. I can see that the lecture has really added to our bank of knowledge. When I came into this meeting was when the speaker was talking about many Ubakas in Nigeria. That is a testimonial about Nigerians. And she also talked about hierarchy in the developed world, whereby if Nigerian physicians come there, for instance, and they do not want to work as a team, they will be told to go back to their country because what happens there is a team. I'm just very happy that the speaker really understood the situation in Nigeria. And I also learned about having antimicrobial stewardship in our curriculum. And speakers, or yes, those making inputs are talking about inculcating that in our curriculum. Of course, that is very, very important. Dr. Nodugo talked about a company sponsoring persons on antimicrobial stewardship training, and the turnout was poor. In fact, I know that many pharmacists in Nigeria do not know much about antimicrobial stewardship. And so IDPAN is really doing great work, and we thank both the lead desk officer and all the members of IDPAN. To conclude, Madam Speaker talked about being the next change maker in Nigeria. When CIPAN started about 2 years ago, we wrote a letter of introduction to American College of Clinical Pharmacy, and they replied us. They agreed to even collaborate with CIPAN. Even though we have not started any official or opened up any official line of communication or collaboration, we already have a fellow of the college giving us lecture, and the lecture has really opened our eyes this night. Madam, I will still plead with you that we shall still invite you at different occasions to help as we become change makers in Nigeria to help build it. Once again, thank you for coming. We appreciate. May God bless you. Thank you very much. And congratulations for a wonderfully well presented very much.
Thank you.
Okay. Thank you, Dr. Madu, the national chairman of CIPAN. And at this point, I would like to invite Dr. Issa Abdulmumi. Are you still here? Dr. Issa? Oh dear. I think he's been bumped off. Okay, he's back. Dr. Issa,
okay.
Please.
Yes,
Yeah,
I'm sorry.
Could you give the vote of thanks and make your final comments before we round off this meeting. Thank you.
Okay, thank you very much. Before I make my comment, please, you are now the host and you will end the meeting. I hope you are using a laptop. That means you have to save the recording before it goes off, because I'm not using a mobile device, not my laptop again, please. Okay. I want to thank Dr. Gore for accepting to be our guest for tonight. It was just a gamble. After the incidents of having her journal article being reviewed by a journal club, I sent her an email and just hope that she would at least even read it and tell us, no, I'll not have the time, maybe some other time. I was lucky that she replied immediately and accepted to be our guest. Thank you very much. Without any history, we accepted to be our guest. Now, we will not leave you at that point. To whom much is given, much is expected. We still need you. We want to have all the things that have been doing in other African countries. We want Nigeria to be part of it now. And not just in the research, we want in the training as well. So we'll be contacting you very soon to help us to design a training that we can have specialist infectious disease pharmacists in Nigeria, in the hospitals, in the community pharmacies, in academia, so that we can also be having publications that will guide our policymakers in taking any decision. I will also plead that you furnish us with the PowerPoint slide after the presentation so that I can share with our colleagues. I thank everyone for coming to this meeting, and I want to assure you that the Infectious Disease Pharmacists Association of Nigeria will make sure that you don't stop at this point. There'll be more trainings, there'll be more opportunities, and we hope that before, in the shortest possible time, we'll have certified infectious disease pharmacists in Nigeria. Thank you again, Professor Go, for giving us this opportunity.
Thank you.
All right. So thank you, Dr. Debbie. Thank you, everyone. We had quite a large number, 94 participants. We
had 100 and had to even stream on YouTube for other people because they could not join.
So that's great. It was very well attended. So thank you very much. We look forward to seeing you again, hearing from you, learning from you, you mentoring all of us. Thank you so much. And
You're
God bless
very
everyone.
welcome. Good
Good
night.
night, everyone.
Good night.
Thank you. Good night.
Thank you. Bye.
Good night.
Thank you.
Good night.
Well done,
Thank
man.
you. Good night.
Good
Good
night.
night.
Good night.
Good night, everyone.
Good night, everybody. Well done. Dr. Isa, are you sure she'll be able to record?
Good night, everyone.
Dr. Isa, are you still there?
Good night,
This recording.